Welcome. What if that new-onset arthritis or unexplained myositis isn't autoimmune at all, but a warning sign of hidden cancer? Hi, I'm Dr. Rezaian. Malignancy-Associated Rheumatic syndromes, or MARS, occur when cancer mimics autoimmune disease. Whether you're a provider, trainee, or a curious learner, recognizing MARS could mean catching cancer earlier and saving lives. They can resemble classic rheumatologic conditions such as rheumatoid arthritis, polymyositis, dermatomyositis, vasculitis, and scleroderma. In some patients, cancer is already diagnosed. In others, rheumatic symptoms are the very first clue. Why does this happen? The immune system is misled. Tumors may produce abnormal proteins or antigens that resemble host tissue, triggering a cross-reactive autoimmune response. Other tumors release cytokines, break immune tolerance, or induce autoantibodies like anti-TIF1 gamma or anti-HU. Red flags suggesting a paraneoplastic syndrome include rapid-onset arthritis or myositis in adults over 50. Symptoms that resist standard treatment are another warning. Constitutional symptoms such as weight loss, unexplained fever, or profound fatigue raise concern. Lab findings may be atypical, such as a negative ANA or rheumatoid factor despite autoimmune features. Additional clues include unusual skin rashes, neuropathy, or new digital clubbing, especially in cancer-prone individuals. Workup for MARS must combine rheumatologic and oncologic assessments. Initial blood tests should include inflammatory markers like ESR and CRP, muscle enzymes such as creatine kinase and LDH, and autoantibodies including ANA and extended ENA panel. Consider tumor markers such as CA125, PSA, CEA, and myositis-specific antibodies like anti-TIF1 gamma. For imaging, begin with CT of the chest, abdomen, and pelvis. If cancer remains elusive, proceed to PET-CT. In women, include pelvic ultrasound or mammography as indicated. Certain clinical patterns suggest specific cancer types. Polymyositis or dermatomyositis, especially with anti-TIF1 gamma antibodies, may indicate lung, ovarian, or gastrointestinal malignancy. RS3PE syndrome, or remitting seronegative symmetrical synovitis with pitting edema, may signal prostate or gastric cancer. Palmar fasciitis and flexion contractures are associated with ovarian tumors. Digital clubbing and arthralgia can reflect hypertrophic osteoarthropathy from lung cancer. Treatment begins with addressing the underlying malignancy. Often, when the tumor is treated, rheumatic symptoms improve or resolve entirely. In parallel, symptom control may require immunosuppressive therapy. Use prednisone at doses of 0.5 to 1 mg per kilodries per day for general inflammation. Methotrexate, up to 25 mg weekly, is appropriate for polyarthritis. For dermatomyositis or paraneoplastic neuropathy, consider IVIG at 2 grams per kilogram per month. Cyclophosphamide, dosed at 0.5 to 1 gram per square meter monthly, may be used for severe vasculitis or scleroderma-like syndromes. Ongoing follow-up is essential. Every 3 to 6 months, monitor with imaging studies, tumor markers, inflammatory labs, and functional assessments. Even after initial resolution, new rheumatic symptoms can herald cancer recurrence. Malignancy-associated rheumatic syndromes remind us that the immune system can reveal hidden disease. When the clinical picture is unusual or doesn't respond as expected, always consider the possibility of an underlying malignancy. At the intersection of rheumatology and oncology, vigilance can save lives.